you for joining this afternoon or this morning, depending on where you're zooming in from. I'm Bill Dempster, President of 360 Public Affairs, and I will be moderating today's discussion on behalf of CORD. Just a couple of quick logistical issues. This is using the meeting version of Zoom, so we would strongly encourage, and in fact, Angela from CORD is going to be co-hosting this in the back end. Please keep your microphones on mute and your video camera off as well, because otherwise that will disturb our flow, and we don't want that. That said, we do want some of your ingenuity questions and comments. Please do put those into the chat panel, which you can find at the bottom part of your screen. So today's session is the first of a series of 4 webinars that are focused on what appears simple, but it's actually a very important question, and that's, is Canada actually ready to deliver for people living with rare disorders? We have an incredible panel, and you can see them on the screen right now. We've got Don Husserow, who leads the genomic testing readiness work, a health economist and pharmacist by profession. He's worked in pharmaceutical policy, I would say almost as long as I have, but I think we'd be in a race to see how long it is. It's getting into the decades now. Durhan Wong-Rieger needs no introduction, President and CEO of CORD. Of course, at the front lines with everyone across the country on this, and also on the implementation advisory group, just stepping away as one of the co-chairs of the IAG of the Rare Disease Drug Strategy, the National Strategy for Drugs for Rare Disorders that the Canadian government has put in place, and which I'll talk to very briefly in a second. And last but certainly not least, because the reason why we're all doing what we're doing is Trish Guimont, who is going to share a very powerful family perspective from the middle of Canada. Let's call it what it is. Winnipeg is the center of Canada for real. Toronto might think it's the center of the universe, but thank you for joining us, Trish. We're going to learn more about your experience with Rett and what this means for you if we get it right. So before we get into it, I'm going to help frame the discussion quickly. Share my screen. So framing the purpose in terms of what this webinar does and what this webinar won't do. Actually, let's step back just for a quick second. We're not making genetic testing the center of rare disease policy, although it's extremely important, and we're going to learn some really important things from Don. One of the things I think that really caught Durhan's eye and my eye was that what Don has done in terms of reporting on jurisdictional readiness to incorporate, implement, adopt new technologies, in this case, genetic testing, is a good analog for what we're trying to do in terms of rare diseases, which is identify which health systems are readier, or the state of readiness in the individual health systems across the country, recognizing that they have different populations, they have different challenges, and different opportunities. And this being Canada, we're going to learn about that in terms of where the different jurisdictions are. And this is going to kick off some amazing things that CORD is leading on across the country, learning from an important case study, which Don is going to walk us through. In terms of what we're going to talk about over the next hour, we're going to frame the system problem. And one of it is that rare disease readiness is not just about the individual technology or medicines that is on a common list. There's a lot more to it, which I think you're going to appreciate, and many of you have already experienced. Then Don is going to walk through the genetic testing readiness case study, which will, show how some provinces can get better than others. I should say, not even than others, improve on where they were before. And Don, I think that you've been through that readiness report a couple of times now, and it continues to expand. So looking forward to that. We're then going to turn it over to Trish and ground our series and what we're doing today in a patient story. So thank you, Trish, for joining us for that. And finally, we're going to move into some ideas that Durhan has been working through with some of the folks that are actually on the line now. And so thank you all for joining us on a phase 2 proposal for the rare disease drug strategy and a readiness scorecard. Last logistical piece, this webinar is being recorded, so it will be uploaded to Cord's YouTube channel. We're very hopeful that we're going to have some folks on the line today from Health Canada and from the health ministries across the country who are going to be taking notes and be a really important part of implementing this. The takeaway message I think we're going to get is phase 1, Canada invested $1.5 billion over 3 years in rare disease medicines, plus some screening and diagnostic initiatives. Phase 2, collectively, the community is looking to build the pathway that stretches beyond just the drugs themselves, and that's diagnosis, treatment, and care pathways. And ultimately, it's about system outcomes and patient outcomes. So let's start with the pathway that patients experience. And this is, if you've been on previous Cord webinars or come to Cord conferences, you've seen that Cord has been working on a socioeconomic burden of rare survey, research, and analysis that is coming online, and we'll be reporting out soon with a few partners on that will come out on Cord's website. But we've seen that there are a lot of issues and breakdown points in terms of the care that rare disease patients and their families experience that isn't the case for many people with more common illnesses. And that's where there are recognition fails. There are an average of 14 visits to GPs, or I should say 7 to GPs and 7 to specialists. So I would say a median of around 14 interactions with clinicians before a patient can even get a diagnosis for what they may have, and that can take years. There are testing fails. Some of these, even if you suspect something, you get a good referral. The getting it from testing to diagnosis is often an odyssey. And then even if you get a diagnosis, and there is a potential treatment, is there an ability for that coverage for the treatment to even learn from how the outcomes are working or not working? Care and support throughout that time, and then hopefully getting that patient outcome. The readiness question that we're going to bring back, and Durhan's going to walk through, are the conditions in place for diagnosis, treatment, care, data, equity, and outcomes to connect through a framework. And that can happen at the national level in terms of a national rare disease strategy, or especially in the case of rare, it will have to be led by patient leaders and clinician leaders, which is what we have here. And why now? Well, there's a very short time limited national policy window. We've got phase 1 of the rare disease drug strategy that's in place now, and in fact we're in the last third of that as we head into the third year. It will end in terms of the current funding in March 2027. So that's not very much time. Cord has submitted to the pre-budget consultations on budget 2026, asking the federal government to sustain funding for medicines, but also build the infrastructure around that full care pathway. And there's a transition risk in March 2027. If we don't have a commitment from both the federal government, but also the provinces that they're going to move forward on this, then we are going to be in a much worse position at this time next year, I think, than we are today. So the budget 2026 ask, I would encourage you to go on Cord's website and check it out. We need the federal government to confirm, operationalize, and expand a phase 2 national rare disease strategy. That won't happen out of nowhere, which is why we're running this webinar series and hopefully holding up good mirrors to the provincial territorial health systems and the national strategy to say, this is where Canada is, ready or not, let's do it. In terms of how genomic testing is an example, well, it's useful because it seems, Dawn, and you're going to walk us through this. It's a stress test of the system. Is the system working? Where is it breaking down? And then where can different jurisdictions learn from one another? Do we have the conditions right to adopt innovation? And will those innovations, as they're implemented, actually deliver the outcomes that the systems have invested in, and that the stakeholders that were involved in your program in genetic testing see in reality. So the proposition for today is genomic readiness is an example. Rare disease readiness is potentially a real implementation challenge. Don, what can we learn from you and your report? And congratulations on getting it published recently in Current Oncology too. You're going to learn a little bit more about that. Over to you, Don. I'll tap ahead as you tell me to.
All right. Well, thank you. Yeah, and I thank Durhan and Cord for having me here. I think the analogy is a good one. When we looked at genomic and genetic testing, we weren't thinking about any one particular type of test. We just knew that in the future, we're going to need some kind of testing for certain applications. We couldn't tell you which one, and we can't pick winners and losers, but we certainly knew that that is going to be part of the future. And the same as I'm sure it can be said of rare disease. We don't know what rare diseases are going to sort of become the ones that we really need to focus on, but we do know that rare disease is going to be something that we need to manage and deal with well within the healthcare system. So, that being said, um, healthcare delivery doesn't just happen. Healthcare innovation doesn't just happen. You need to have conditions that are conducive to its consideration, adoption, execution, and even monitoring. And so that was the focus of the report. So, our original focus on genomic genetic testing, there were some folks that were, interested in this in the cancer space, but it became quite apparent that in order to be completely ready for a future of what I'll call genomic medicine, genome and genetic testing, um, you couldn't just consider cancer in and of itself. You had to think about how genomic testing was going to be delivered writ large, like looking at rare disease, looking at non-cancer conditions like cardiovascular disease, looking at cancer. Even in public health, we use genomic genetic testing as well, although that was beyond the scope of the report since public health tends to operate in a different vein. So, yes, so why assess readiness? Well, as I said, we knew we needed to look at these conditions. We knew that we weren't sure exactly what those conditions were, but we knew that that was going to be part of the project, was to sort of come up with a consensus based on literature, based on consultation with experts nationally and internationally. And then once we do that, then map out and say, how is Canada doing? So, and I'll get into that in the next slide. So again, we dealt with hereditary testing, cancer testing, not public health, not testing in public health application. So yes, here's how we did it. As I said, we gathered evidence. We looked at what conditions probably matter. We talked to a lot of people, and we defined conditions. Um, Conditions we said that are necessary for the consideration and adoption of testing, so that it conforms with the aims of the quadruple aim, that is, patient health outcomes, uh, uh, patient experiences, reduction in costs, and caregiver experiences. Um, Once we found those conditions, we made sure that they were the right ones. Then we went off, and in 2023, we looked at um, five provinces: BC, Alberta, Ontario, Quebec, and Nova Scotia. And in 2026, we come back and looked at the entire country. The conditions that we identified, well, we put them in three different buckets. One we called an infrastructure condition. It was looking at both the infrastructure of human capital, communities, and networks. We looked at the ability for healthcare systems to plan. We have to be mindful that testing is done province by province, just as rare disease delivery, being ready for rare disease is going to be done province by province. And we also looked at information systems, which are key and critical to delivering and both developing and delivering genetic, genomic testing in an efficient and effective way. We looked at operational conditions. We looked at how well the healthcare system will be good at considering new tests and evaluating them, recognizing that not all tests are valuable in all contexts. So you do need an evaluation function of some kind, although it should be an evaluation function that is timely and and still valuable to patients. Can't be delaying access to appropriate care. We need service models that coordinate around genomic testing because there's a bunch of ways that you can go wrong with testing that create duplication and inefficiency and are actually disenfranchising to patients. And you need awareness and navigation functions for clinicians and patients so that people know where to go to get testing. People are aware that testing is available, and people are aware of what tests can do and what they can't do. The third bucket was healthcare environment conditions. Testing is not something like a drug where you can adopt it from one day to the next. You need to be really prepared for the future. We looked at attitudes towards integrating innovative tests. We looked at financing approaches since traditional approaches to financing tests may not apply to genetic and genomic tests, which require much more health human resource. We looked at education and training of both clinicians and also education and training strategies and whether those were available. Education was also available for patients. And then there are also conditions related to regulation and quality of tests, which to make sure that the tests you're getting in one jurisdiction are going to be as reliable as the tests you're getting elsewhere. So we took all of these conditions, we mapped them out. We'll go to the next slide. And in 2023, we looked at the number of conditions that were being fulfilled. We looked at whether the condition had been established or maybe partially established. In many cases, it had been not established, or in some cases, they'd said, well, we're planning to do this, in which case we'd say it was partially established. And at that time, we saw Alberta kind of had its act most together, followed by Quebec, and other provinces were sort of behind. Ontario was just at the cusp of developing some strategies, but everything was in development, and nothing was really consolidated or together at that time. Um, since then, in 2026, we've taken a relook at this. We see some changes. Alberta became more transparent about their evaluation framework, for example. There was BC and Alberta led some projects around innovation. Ontario developed its program very strongly, came up with province-wide educational standards and other tools. They have a stronger process. Quebec and Nova Scotia also improved processes. And in the background of all this, although it doesn't affect any particular province report card, we know that CDA-AMC has worked towards sort of a pan-Canadian approach to looking at evaluation as well, which could serve province as well. So what we did see ultimately was the provinces ultimately were in a more narrow band of being ready. We assigned grades. We knew that there's evidence to suggest that grades can motivate policy change. And we also, we worked very closely with people on the ground and also spoke to ministries directly. This was not about just producing a report. This was about going off and communicating things to make sure that meaningful change was going to happen. So we're seeing progress, and we're seeing, and these are scorecards in time. I think we've seen even further evolution in BC since publication of this report. We know that Quebec and Ontario are still doing things, so things are slowly improving at different paces in different provinces. Next slide. Um, so yeah, progress is real. We are seeing some progress. It is, in policy, it's always the glacial pace of change. I know that's always very frustrating, particularly if we're a patient and things are not glacial for the patient who needs something today. But unfortunately, and we saw this in Ontario in particular. Ontario is a very large system. Well, very large systems take a long time to kind of move the ship. Huge ecosystems take a lot longer to change. We saw, smaller provinces had the advantage of being nimble and being able to do things quite quickly. There's fewer people, there's fewer moving parts, and the like. Um, so we also saw, the real impact of governance. And so when we look at BC, BC is a province that, back in the day, like many provinces, regionalized, and slowly they've been trying to de-regionalize. But regionalization is a structural feature that can create real problems for a technology or an approach to medicine that requires integration. And I think this is something that we're going to see in rare as well. Rare disease is probably going to have to be managed. I mean, first of all, we need its appropriate application no matter where you live, and so that is uh, problematic sometimes when we have very decentralized healthcare systems. So, but BC is well aware of the things it needs to do, and it's still moving along. We saw uh, so and so we see different grades reflecting different things. There's still gap areas though we see persistently. One is like the obvious engagement. Um, it's not shown on the bottom here, but a lot of provinces very much focused on engaging only with the inner circle. Let's talk to laboratory leaders. Let's talk to clinicians. Let's not let anybody know we're talking. Ontario has a laboratory formulary committee, for example, in their provincial genetics program, but you can't read about it. You don't know who's on it. You don't know how long they take, etc. They do have a very transparent technology assessment process through their OGAC and OTAC process, but that works in parallel. So there's still some gaps in terms of broad engagement and in all provinces. But good systems of evaluation, look, genomic testing are always going to require us to pick what is valuable to the system, what's not. But that should be done in a transparent fashion, adhering to good principles in HTA. Unfortunately, in Canada, we're not always seeing good principles in HTA being applied. So we have a lot of work we could do there. Financing approaches, we still see most provinces don't pay for the development of genetic and genomic testing, for example, except for Quebec. So, how are we supposed to then have these things in place if the province is not funding that? Linked data systems is a huge problem that goes beyond testing. Obviously, provinces are working on IT infrastructure. Those are massive investments. So, that is very glacial in terms of its pace. And then education and navigation. Different provinces have different approaches. Ontario's done quite well, and Quebec to some extent with some standards around that, but there's much more to be done. Next slide. I think this is the last slide. So ultimately, readiness does come down to it's a system property, and I think that's correct. I think one of the lessons for me is how important governance is in everything, and of course, I think we all know that in everything we do. If you don't if any organization doesn't involve, for example, patients at the highest level, well, guess what? Then patients aren't involved at the lowest level. So, this is an important aspect of what we do, but governance plays a big role in being ready system-wide because if we have a system that is not fully integrated, then it becomes more difficult to be ready system-wide. We need like these heightened coordination functions. And coordination is much more difficult to do than having a more centralized approach. But centralized approaches have their own issues as well, and that's the essence of creating governance, is trying to understand the balance between centralizing and decentralizing. So, systems need to be able to plan. They need to allocate capacity more easy in a centralized environment. So Alberta gets good marks. They have Alberta Precision Laboratories, a big laboratory-based organization for the entire province. So that's their remit, is to think about testing. Evaluation needs to happen. Different provinces have different evaluative capacity. Some of them have HTA models, but then they're not adhering to good practices in HTA, transparency, engagement. And those are the things we need to see in HTA models. Good deliberation, not sort of closed door, uh, don't talk to us, don't ask us to show you what we did type of approach. And also certainly not long, but there are some provinces that are still taking 2 years to decide on a test. That's not realistic in the world of rare disease, for example. Financing, provinces, it's hard to evolve financing approaches because you have to spend more money. So, but we saw in testing where things were lacking, and navigation, and making sure we learn from what we're doing. These are always considered nice to haves, but I think they're essential to haves in complex testing. And so if you want to read more about this, these are the QR codes and links for the reports, and I think the slides will be available afterwards. Um, and I think that's all I have to offer now, Bill.
Thanks, Don. That was terrific. As you've been hanging on this, just take a picture of this slide if you want to go and visit these reports right away. But as you said, regardless, these slides will be available on Cord's SlideShare channel, and this whole webinar will be uploaded to YouTube. Now we're going to hear from somebody who has experienced the system right up close, and I invite you to join us on screen, Trish. Oh, there you are. Okay, great. Um, Hoping you can share with us a bit about Emma's story and your story, really, and where the readiness gaps for adopting access to a rare disease treatment just weren't there, but maybe even starting earlier than that, in terms of even getting a diagnosis. So, Trish, if you wouldn't mind, just walk us a bit through your diagnostics pathway, and getting Emma what she needed in terms of even knowing what she had.
Bill, I think we're going to kind of do it a little bit like a Q&A, if that's okay.
Yeah, absolutely.
Okay,
Yeah.
all right.
So,
So,
yeah.
yeah, oh, Trish is unmuted, so
Yeah.
that's great. Trish and I talked about this ahead of time, so we want to make sure we get to the key point. So this is helpful. Trish, first of all, thank you so much. Trish Guillaume is a parent, as we have you've suggested here. She has a daughter who has Rett syndrome, and she's going to share with us a little bit about her both diagnostic and access to care and treatment odyssey, but also they also share us with some of the victories they've experienced. So that's a really good point. Trish, so maybe just introduce yourself and what your role is with regard to the Rett syndrome in Manitoba.
Sure. Thank you first, Duran, and for Cord for having me. I am a parent, as you said, of a young lady, Emma, who has Rett syndrome, and I also am the president of the Manitoba Rett syndrome in Manitoba. So that's where I come from with on this journey.
Thank you. So, relative to the pathway that Bill alluded to, maybe you can just tell us kind of when did you first notice symptoms, challenges, and how long did it take you to get to an accurate diagnosis?
Yeah. So we started noticing things about when Emma was about 12 months, or just a little bit younger. Emma is the youngest of 5 children, so we'd already gone through the journey a little bit, and she stopped progressing. She stopped sounds that she was making. She seemed not to be able to make them anymore. She wasn't meeting milestones like we had seen with our older kids. She had sleep issues and unexplained fevers. And we knew something was going on, but we just weren't sure what. So I did a reach out initially to our pediatricians at about 1 year old, when she was 1, and they had said to wait it out. I was a little bit persistent, so then I went to my health nurse instead and said, I think there's something going on. Could you please start the process of getting us on wait list? And she did that for us. So during that time, from when I saw the health nurse to the diagnosis, Emma ended up with a few different diagnoses. She received a global delay diagnosis, an autism diagnosis, And it took us almost 4 years to get to the final diagnosis of Rett syndrome. And it was just before her 5th birthday.
You have a little story about how you actually kind of got recognized that she might have Rett syndrome, which I think, as Emma sort of alluded here, it's a really difficult disease to diagnose. So no fault necessarily to a pediatrician.
No.
Rett itself is multisystemic. It shows up in different ways in different people. And so, not to say that's a good excuse, but how did you actually get twigged to the fact that she may have Rett?
Yeah. So you know what? We happened to just be in a hockey arena one day. My daughter was playing hockey with a fellow she was playing in a hockey game, and one of the other parents happened to be sitting there with me, and I think I knew I looked stressed, and she asked me about what was going on, and she happened to be a nurse, and so she had said to me at that point, "Do you know what Rett syndrome is?" And I said, "No," but we went home that night and we Googled it, and sure enough, that's exactly what we saw in Emma. We knew then that's what she had. It took a little bit of persistence and pushing for genetics to test for Rett syndrome, just because they hadn't seen someone like Emma, all her symptoms and what it looked like. They had seen Rett syndrome look in different ways. So that is how we came. So it was just by chance that I came across a parent who had seen Rett syndrome before.
Yeah, and so it might have taken even longer if you had not persisted and gotten the genetic testing. So tell us a little bit about, so where did the system then fail to connect the dots, right? We're looking at this little bit of timeline. So what happened?
Yeah, so I think right from the beginning, maybe we started that things weren't connecting. She had multiple things happen, the regression of sleep and GI issues and everything. And so we weren't really connecting. The system wasn't connecting all the dots together. We weren't looking at it as a whole. I had concerns about seizures. I'm epileptic. I thought I was seeing seizures, but nobody would really believe me until she had one in the hospital one day. And so that started that movement. In genetic testing, we did actually come up with another micro deletion. And so that's, again, where we thought the journey was going to end. Everybody was okay with that diagnosis of global delay, autism, and then this micro deletion. I knew there was more. And so, or we thought at least there was more. And so that's why we kept pushing. Rett syndrome really just was diagnosed through chance for us. And so as going through the system, we just had to keep pushing, and really nothing connected. But in the end, with the help of a nurse, that's where we ended up connecting the dots.
Yeah, so I'm going to ask you maybe a little bit painfully. So what would have been different for you, Trish, if there were a system that were able to connect from your first concern to getting to genetics testing, getting a diagnosis, getting specialist care, and then getting treatment access? So what might have been different?
So first of all, getting answers sooner would have just the basics, right? Our mental health stress, financial stress that it took for paying for therapies out of our own pocket, having to leave work. But we would have known what to do next if it was connected. We thought when Emma received the diagnosis, I thought that was going to be I thought we would have a roadmap and it would be easier, but in the end, it ended just being as tough and more difficult. We've spent years navigating the system and looking for help for treatment. And even today, those same challenges are still there for us, right? We have the first drug available for Rett syndrome in Canada, and yet it's been approved by Health Canada. It's not recommended for funding. So even with trying to apply through the Manitoba government and being denied funding, we're still now at a crossroad, right? We don't have a ready pathway to move forward and make it any easier for any of us.
Yeah, so I think, in a very small capsule, right, you've captured a lot of what it is that certainly, what Don alluded to in terms of being system ready, not just, kind of having the test there. But the tests were there, but the system wasn't ready. And then also system ready once you've gotten a diagnosis to be able to pick up on the care. And I think, as you say, sadly, even today, when we get to the first treatment for Rett syndrome, brought into Canada, actually was, I think, fast-tracked by Health Canada, and yet at the end, it was not recommended for reimbursement. So, I know you've been diligently, kind of advocating with the Manitoba drug plan to try to get access for Emma. But of course, it's hard, it's a hard push when
It
your
is.
system at some point falls apart and says, no, thank you.
Yeah, it's been a very difficult road, right? There's just no end in sight. We, originally thought when those genetic tests were done, we had an end in sight. We knew it was going to happen. And it hasn't really got any easier.
Yeah. Well, thank you so much for your story. But even more importantly, we know how much you're doing the advocacy. We know how much you contribute, not just to the Rett syndrome advocacy, but how much what you're doing is contributing to our overall advocacy for rare diseases, and really does show kind of what the challenges are. Maybe we'll get a little shot of Emma. So tell us what this is and what you're proud of here.
So yes, we're very proud of Emma. The journey, as I've just stated too, has been such a long road. She's had some severe health issues the last few years, and so this was just this past week. She graduated yesterday. She was convocation, and we celebrated her getting through grade 12. So that's a huge accomplishment for us and our family. And years ago when we got that genetic diagnosis, we didn't think we'd even be here. So very proud of her.
Thank you very much. And it's certainly a real credit to the whole family in terms of where you are. And, if there's someone who deserves to get access to a treatment that could improve, I think you can see Emma here, but just a beautiful young lady. So huge congrats and congratulations to Emma as well. I'm sure we'll be seeing more of you. And hopefully, the next time there will be some better news. So thank you so much for that.
Thanks for having me, Durhan.
Thank you.
Yeah. Chip, we're going to just move into where Cord is taking these lessons learned from both Emma's journey and Trisha's experience, but also the work that Dawn's been doing on genomic testing. In a second, I saw Keith had his hand up. Keith, I'd encourage you to just put your question or comment into the chat box, and we'll do our best to engage with you there, because we've got a lot to go through. And I'm going to hand it back off to Durhan to talk about what is this lesson learned that we're going to take from both that story, but also Dawn's experience on genetic testing, and what's the relevance to what Cord's going to do in terms of system readiness for rare diseases. Durhan, walk us through. I'll click ahead as needed and talk to Keith on chat.
Yeah, thank you very, very much. And thank you so much, Trish, for sharing. And I didn't realize she was the fifth. So, as you say, by that time, it was pretty clear to you that this was not a normal progression. So even more challenging it might have been. So congratulations very much so. And I'm sure you're proud, and I'm sure Emma's very proud as well. But I'm looking at our list of participants here who are on the thing. There are lots of parents in here, there's lots of patients in here. And I think each one of you would have some of those stories and can share that. And of course, we should not be doing that. Let me come back to the kind of where we want to go. As Bill indicated, we're more than halfway through what would have been the 3-year, $1.5 billion allocation for a rare disease drug strategy. We will be looking forward to, and I sit, as Bill indicated, on the implementation advisory group, looking for a report to come out by the end of September. And I don't think I'm telling any tales out of school to say to you that report is not going to guarantee us anything in terms of the future. We're going to have to fight for it. We're going to have to make the case for it. And we're going to have to lay out a plan for what we want to do in phase 2. Obviously, genomics is really important. A lot of genetics and genomics there, but as Don indicated, provinces are not necessarily ready yet. And quite frankly, even if they were, what Trish's story has shown us is that if not getting to the patients, if you're not aware as a clinician or as a parent to say, I need to have that test, you're not going to get it. So I think this is important. So yes, the readiness, yes, the capacity has to be there, but we need to connect the dots, as we said in Trish's story. And we don't want to think about how long it might have taken to actually get the diagnosis if she hadn't had a lucky encounter, with another mom. And this is true for many of our stories. So yes, genomic testing is one of it. And as we know, not all rare diseases are genetic and genomic. So there's a whole host of rare diseases that are way beyond that. Okay, so next slide, please. talk a little about where we want to go. So that was phase one. The rare disease drug strategy was great. It provided an injection of funding into the provincial systems. I have a little question there. The $1.5 billion was allocated by Health Canada, by the federal government, distributed to the provinces based on population, with the goal of funding drugs for rare diseases, but also asking for investments in terms of screening and diagnosis for follow-up. And what we do know is that this has been an important starting point, but it isn't the end point. It's not enough. So we've got medicines, as the government saying, yes, what Don has indicated and what we know is that the rest of the system has to be there. And as Trish says, even having some funding for drugs does not mean that everybody's going to get a drug. Not every patient's going to get a drug if it comes around, and that we need to do a whole lot more to ensure. So we've got to make sure that we are investing, as we say. A drug pathway is great. We've got funding for drugs in this first 1.5 billion, but it's not going to get us there if we don't have strategies to identify and diagnose, if we can't confirm the diagnosis, if we don't have the specialist centers to actually deliver and monitor the drugs, and that we can learn from it. So what else do we need to know? What else can we do to follow up? I think this is the challenge for us in this call for a phase two. Thank you for the drugs, but now let's get to hard work in terms of getting the system ready to deliver not only those drugs, but to deliver for all of our rare disease patients. Next slide, please. So what are we going to do? What do we want phase two? Phase two hopefully should kick in when phase one ends in the March 2027. Obviously, we want to sustain funding for medicines. This has been important. It's helped jumpstart the access to the medicines. What the government said in phase one is here are 12 drugs, and it was up to 15 drugs that need to be put into drug formularies as soon as possible. And some of the provinces did indeed make those available. And we know that where those drugs were identified by the monies, patients did get access much quicker than they would have under other circumstances. But what we need in phase two is we need to have, an alignment around the objectives, the reporting and accountability. Not all the provinces are able to report back how they've dispensed the monies, how they're following up in terms of the drugs. We need to make sure that that implementation is visible, measurable. We've been asking, as the implementation advisory group even, where are the deliverables? What are the indicators that we're using that money effectively, that the monies are actually being allocated to rare diseases the way they were intended to, whether it's for drugs or whether it's for other parts of the system, how are they being used? But I think most importantly, we want to make sure, and so we can see in 4 or 5, that we are funding into an ecosystem. And I think this is really what's important, right? That we're not just funding the drugs, but that we do fund the pathway, and that we take, Trisha's story here with Emma. What do we need? We need to get the diagnosis. We need to make sure that we've got the data and we can get them, not only that we're getting the diagnosis, but it gets to the right healthcare provider, get the right healthcare system. They're able to provide not only diagnosis, a recommendation for care and treatment, but if there are treatments that we get access to those treatments, that the infrastructure and that they're connected. And I think too much patients, even where there are good therapies, are the ones that are really, kind of the ones that are trying to put the system together. And we're going to hear in some of our upcoming series, some of the healthcare professionals, and the real challenge for them when there is not the dots aren't connected, the burden that falls on either the frontline physician, but oftentimes the specialists to try to make those connections, and the burden it falls in terms of the families to get from it. So what we need is an ecosystem that is as good as the drugs that are coming in. So these are drugs in that in the list. I think I saw a question on it. Those drugs that were identified in the list are innovative therapies, all new therapies coming in. In theory, meant to be life-saving, life-altering therapies. So their therapies have been approved by Health Canada, been deemed by the drug agency as saying, yes, they have real value, and then are negotiated in terms of a pricing that's going to be affordable across the system. As many of you as patients know, sometimes even after that step, it may take years before they're available in the formularies. And so what this is intended to do is to jumpstart that process. Drugs are made available. We would like to see this process start much earlier, even at the time of the Health Canada approvals, without waiting for all of the other steps to go through. But, this is the whole notion of it, right, in terms of being able to get an ecosystem that's able to do the diagnosis. One of the important things I will mention is that, even for those drugs, life-saving, life-altering drugs are on that list, meant to get to patients right away. We don't even identify the patients. I've asked some of the companies, what percentage of patients do you think that are eligible for treatment do you think you've identified? And I get as few as 20%. We can't find the patients because we don't have a screening and a diagnosis program in place. How many of them are you able to follow up to determine how well the drugs are working, and that we can reduce what the system has called, kind of lack of pre-trial, clinical trial data to really demonstrate how well they work? Nobody. And I think this is the challenge, right? So we put in one step, we've got to put in all the other steps. Otherwise, patients are not optimally served, and the system itself, Canada itself, doesn't get the value from it. The next step, please. Next slide, please. So this is what we're saying. Little fast. Go back one. This is what we're saying is that what we want to do is to create that backbone. And we've developed a logic model that wants to look at three components. A bit of what Don's saying in terms of the genomic readiness, right? Do we have a system in place? Is there policy? Is there funding? Is there a workforce? I think is what we've heard also. Sometimes we hear the real barrier to doing genetic testing and genetic and diagnosis is that we don't have enough genetic counselors to deliver the results to patients. I mean, that's a crime, is that we have the information, but sometimes it takes a very long time for the patients and families to get that information because we don't have enough genetic counselors. There are strategies taking place right now. I'm very excited about the work for, people like Robin Himes is doing in terms of saying, can we train other people to deliver, genetic results? Doesn't have to be, somebody has a PhD in genetic counseling or even a master's in it. We need to make sure that we can get results to patients and families in a timely fashion. So where's the infrastructure? Where's the work? But beyond that, then, do we have the system in place? As Don says, do we have the components in place? Now let's measure how well they're being delivered. If I've got newborn screening, how many tests, how many diseases are we screening for? They're not the same across the provinces, but one of the things the Rare Disease Drug Strategy did do for us is give us a newborn screening panel that says these are the core tests that Canada should be screening for, and suggested that some of those monies be used to make sure that we have equalized screening across the country. Once upon a time, as some of you will know, some provinces were screening for 3 diseases at newborn screening. These are tests that could be administered through a heel prick that could identify a child being born with a serious, with specific diseases, oftentimes metabolic diseases, but others as well, so that you can actually intervene, maybe do preventive care, maybe get them to the right specialist, maybe even get them to the right drug, before they're symptomatic or before the symptoms progress. So how well are we delivering it? So do we have the system in place? How well are we delivering it? And most importantly, we want to be able to measure what's the impact. How many patients did we diagnose? What was the journey? Were we able to impact the journey so that we don't have what we have found, and you're going to see in some of our upcoming research, that it takes oftentimes years for a patient to get from getting initial indication, as Trish says, to actually getting to a diagnosis. And we need to reduce what we're calling that diagnostic odyssey. So how much and how long? What's the economic impact on families? We'll hear in the upcoming webinars we've got, how much it costs patients. And how much a delay in diagnosis, a prolonged diagnosis, actually costs extra to the families, as Trish indicated. All the things you're paying for yourself, all the different trials and strategies you're trying, some of them don't work. Some of them actually cause harm. Sometimes they could have been paid for by the system if you got a diagnosis. Sometimes they could have been paid for by the system if you got access to the right treatment. What's the impact on patients? What's the psychosocial impact? What's the mental health impact? And how equal, how equitable is this across the country? Next slide. So this is what we're going to be doing, and we really are going to reach out to all of you to join us in this. We're really excited that Canadian Rare Disease Network is partnering with us. They came in as a partner at the very beginning when the drug strategy was announced with the setup of the Canadian Rare Disease Network. And I know some of the leaders in that network are on the call today. And what we're going to be doing is working together. We want to work together to not only advance the diagnosis, but we all the assessment of the system, but we also want to work together to coming forth in terms of recommendations. So this is a process that we will be engaged in, identifying what we should be measuring, getting consultation with all of you here as to whether or not these are the right things to measure, how should we measure it. But as importantly, and looking at some of the people that are in the provinces, in the action groups, having you go out and help us find that information, and then we are able to kind of come back to say, okay, what are we doing now? What is working? How do we measure that? And it serves not as a grade card, but really, and I'm not sure we're going to give it grades, Don. I know the provinces shudder at the idea of grades, but as you have demonstrated, it gets their attention. I said to one of, I'll tell this story, one of the people within the Ontario government. I said, we're going to try to do something like a readiness scorecard, sort of like Don's genomic readiness card. They said, oh, God, no, we hate that. I said, well, why do you hate it? He said, because it gave us grades. And I said, yeah, but, you did better in the second round. You went from being a D to a B. And he looks at me and he says, oh, well, then maybe I like it. So I think it's an encouragement for them to do better, and they actually do want to do better. I think inherently we do. So it's not a judgment. It's a really saying, where are we now? Where do we need to do better? And where are the places in which we can do better? And maybe sometimes can do better without, a whole lot of other additional investment. Some of that integration can be done. So this is what we want to do. And we're just delighted to be working as patient advocates, also with the clinical and the research advocates to actually start to talk about how do we improve the system. And some of this, we're hoping that we can begin to do, that we can really encourage the provinces to take the monies they've gotten through this rare disease drug strategy to start to apply it to actually improving not only the delivery of drugs, but also the infrastructure. And we do hope, as Don says, we can do this again in terms of a scorecard, and we will see where provinces have improved. So this is the goal. It's a bit more than just genomics, but and we're going to pick and choose in terms of what things we're looking at. We would love to have every province do what Quebec did, and that is to give us a whole provincial rare disease strategy, rare disease plan. We don't know that that's going to happen. We don't believe that's going to be possible, though Ontario was well on the road to doing that. But we can identify key elements that we think can be improved, sometimes can be improved fairly easily or readily, with, some changes in terms of how we're implementing. So this is our goal. So next slide, please. So this is kind of what we're going to do, taking a page out of what Don did and really borrowing from what the United Kingdom has recently done. What are the domains we want to look at? We can talk about what those indicators are going to be. And we want to use a scoring rubric. So, is there a registries? And if there are not, they get a 0. If there are registries, but they're not really kind of very widespread, or if they're very specific to one site, then we need to, kind of look at how we can do better. Is it, do we have care pathways? Are they defined? Are they being implemented? Are they actually being, provided with in terms of resources? So, hopefully we can identify kind of what's working, but also really what's not, up to par. And then hopefully where are some easy places that we can begin to make improvements. Next slide, please. Oh, okay, I won't belabor this. We've been working with the United Kingdom in terms of the evaluation of their rare disease framework and their new rare disease action plan. And we believe there's a lot we can borrow from the measurements they're using and how they're actually doing the evaluation that's going to help us. And they've been very open in supporting, willing to support what we're doing. We've also been supporting what they're doing. Next slide. And so this is the most important part. We want to go from a scorecard to action planning. And I think this is what everybody's talking about. What's the current status? Where are there some real opportunities for us to be able to, as we said, which first link up the dots? Where are the most critical breaks in the pathway? Is it from diagnosis to getting access to a specialist? Is it from a specialist to getting access to really good care? And what kind of care are we, having the most challenges on? And then what are some priorities that we can't do everything? What can we do? And it may be different And we may only look at 2 or 3 provinces and say, can we work with you in order to, improve that? Use it as a bit of a pilot, use it as a bit of a demonstration. And then we can measure the progress as we go forward. So we rather, kind of focus on what we can see some real achievements on rather than say, okay, we need an overhaul of the entire system. Not going to happen that way, but we can make, as we say, measurable progress. Next slide, please. And that's it. I have an optimistic 90-day program. It may or may not happen in 9 days, but we think that we can at least get to the point where we're doing some testing of the measures and being able to work with all of you to say, are we measuring the right things? And I think that's it.
Fantastic. That's great.
Okay.
So yeah, what we're going to do next, Durhan, and I just wanted to throw in why the UK, because I know that would be a question. It's also a federation like Canada. It's jurisdictions, which in their case are countries, and they're actually playing. As anyone watching the World Cup these days will know, as different countries. But at the federal national level, it's a bit like the federal government here in Canada in terms of what it can do with the health systems in England, Wales, Northern Ireland, and Scotland. So, yeah, how to move from commitment to readiness, Durhan. What's going to happen next in terms of the webinar series this summer and a launch, hopefully, of a similar project to what Dawn did on genetic testing?
Yeah, let's do the next 2 slides quickly before we lose people because it's really important. So, okay, move to the next slide. So this is our series, and this will be available, as we say. You'll get invites to it. The next webinar is going to be July 14th. We're really going to hunker down on the court survey that was done, looking at the social economic impact on patients and families of trying to get access to the right care and treatment for rare diseases. Session 3, we're going to really look at readiness and have some talks about what the system is doing now and what it's not doing, and hopefully engage some of our healthcare professionals as well to talk about where they would see some of those investments needing to be made. And then the last one is what are we going to do to really get prepared in order to make Canada a real innovation hub for rare diseases. And it goes a lot to, not just, MFN, the most favored nation, but also encouraging investments and also encouraging the research that we have in Canada to be, prepared. So all of these are part of what we want to do in August so that we can get ready for having a response to the report that's coming out, but also preparing for a proposal, backing up the proposition that we've already put into the budget, but also putting in plans for how we think we as a community can make some of this happen. And then the last slide is something hopefully that the patient community has heard in the audience. Trish was good enough to kick us off by providing a story, about her journey. And it's been really, I'm sure all of you will have, recognize how impactful that was to hear firsthand. So Don and I can talk about the system all we want, but you hear from Trish and it really is the validation of what's wrong with the system, and what needs to happen in order to make it work. So what we're asking you for is what are the moments that matter? Trish came out with one and we asked her before, like, what would have happened? What could have made it better? And I think, we cannot rely on, your chance meeting with the hockey mom in order for you to get your daughter diagnosed. But maybe that was the moment that mattered. What was the moment that mattered to you? We've put out a survey. You can see there's a link to the Survey Monkey there. There's a QR code to get to the site. We also, to get to the survey, we're asking all of you to kind of survey only takes about 8 minutes. It's not long. We're not asking you to give us your entire patient journey, but to help us understand kind of what was important for you. What are the moments that matter? What are the critical parts in the pathway that are working? And importantly, what are the ones that are not? And we're going to keep these and we're going to use them throughout our advocacy program here. And hopefully, even as we move into proposing plans, that we can use this to help illustrate what it is that needs to happen and what that happening can mean in terms of patients. So I think that's it.
Excellent. We're going to send out the URLs or links to all of these things, including Dawn's report, the survey. This has been a very QR code heavy presentation. So you can click through after watching this, or you can wait for your email and then go and explore more. And if you do participate in that survey and something really, catches Durhan your eye, we might bring you forward in a future webinar so you can share your story live sometime over the summer. Dawn, thank you so much for your expertise and your experience leading that genomics readiness report. Not just report; it's almost an ongoing program by this time. So congratulations for expanding it to the whole country. Love to see how it's having an impact in terms of implementation. If people are waiting for the next iteration to say, "Hey, I want to get to B plus," it's time for us to do that in rare. So really appreciate it, and hope you can stay along for the ride as this also gets moved forward in rare diseases. Durhan, any last things that we need to say before we close this out and wish everyone a great day?
No, just my huge thanks to Bill Dempster from 360, who is our moderator and, is my lifelong companion here in terms of everything we're doing in terms of rare. You know that we can't do without you, but really also thanks to everybody who listened. There were some questions here. I know that Bill answered some of them. The ones that we didn't and we will definitely answer for you. And please do join us. We're going to come back on, I think, July 14th for this, and I think you'll hear some, really important information about where we are in terms of the impact of rare diseases. But honestly, everything we've done in rare diseases, as you know, has been driven by the community. So without that, we would not be able to make the case that we have. And, we need to make sure that 1.5 billion wasn't just a one-time shot into the rare disease needs, and that we are able to continue to be able to provide for patients with rare disease. So thanks a lot, everybody. And hey, Wayne, thank you. I hope you're better. I hope your arm has healed. And Wayne Priestley was once our chair, still a long-term friend of the board of directors. And poor Wayne was coming in for our last conference and slipped and broke his arm. So thank you for being on here. I guess it only takes one finger to actually join the webinar. So we appreciate that.
Excellent. Take care. Thanks, everybody. We'll see you on July 14th, if not earlier. Bye-bye.